Hey all, welcome back to the Real Life Pharmacology podcast on this special episode, part 2 of 2 on the Beers criteria. Before we get into that, do go support the sponsor, meded101.com/store. We've got some next level study materials for BCPS, ambulatory care, BCMTMS, NAPLEX exam, lots of different resources there. At meded101.com/store that can definitely help you prepare for and pass your board exam. All right, so let's get into the drugs contained within the Beers criteria, part 2. Continuing on, I left off on some sedative type medications with benzodiazepines and Z-drugs showing up on the Beers criteria. I wanted to add to a couple of those. So, not used very often, but they're older kind of anti-seizure type medications in primidone and phenobarbital. These two medications I have seen occasionally used, probably primidone a little bit more so than phenobarbital for the use of management of essential tremor. With that said, these medications do show up on the Beers criteria for their risk of dependence. Also overdose risk if patients take too much. It's significantly risky. It can increase the risk for sedation, confusion, falls, may even cause some ataxia type situations for patients. So definitely a couple medications to avoid there within that class of drugs and older anti-seizure type medications. All right, getting into some hormonal type therapies. Let's talk testosterone. This medication should be avoided unless you've got a specific diagnosis of hypogonadism. Historically, I have seen providers occasionally try to use it to basically stimulate energy and muscle strength and that type of thing. But again, generally not recommended for that purpose alone. So definitely want that indication of hypogonadism if we're going to consider using testosterone therapy. The big reasons why are cardiovascular risks, like heart attack, for example, strokes, and then prostate cancer can exacerbate or worsen that situation as well. The other kind of hormonal medication I wanted to mention was estrogen therapy. So systemic estrogen therapy can increase the risk for breast cancer and blood clots. So that's why it's avoided. Occasionally I've seen some of that estrogen therapy linger on into older ages. So naturally kind of the most common course is at menopause. Females will get put on it to help deal with menopausal symptoms, such as hot flashes, for example. And that drug can kind of stay and linger. And patients may not want to try to go off of it or reduce it due to kind of a return of their symptoms. But it's definitely a medication you need to reassess. And we need to slowly titrate that down as patients age. We want to minimize the duration of use if possible in females taking estrogen therapy for those symptoms. And again, that's because the risk of certain types of cancer like breast cancer, blood clots, and things of that nature. So definitely important to recognize that. Now, topical estrogens don't carry as much risk for that stuff. We don't get a ton of systemic absorption there. So for localized, vaginal type symptoms like vaginal dryness, for example, maybe even prevention of UTIs, that type of estrogen therapy is considered acceptable use. But it's that systemic estrogen therapy that can definitely increase those risks of those negative outcomes that I mentioned. All right, getting into a couple of medications, or I guess medication classes regarding diabetes. So we've got sliding scale insulin is not recommended. There's an increased risk for hypoglycemia. And when you're using sliding scale, you're strictly giving insulin based upon a blood sugar reading. So you check blood sugar, it's at 400, now we're going to give sliding scale. Well, you're kind of too late. You really should have given that insulin a while ago, and that's why we, tend to prefer to give that insulin with meals or, right after a meal when people are going to eating to prevent that postprandial blood sugar spike. But when you're doing it kind of retroactively, where you're basically just checking the blood sugar and now giving insulin, you end up kind of with this yin-yang scenario where you get these high spikes and then it can drop precipitously quickly, and you can end up with hypoglycemia. So again, sliding scale, definitely not recommended, especially long-term, as any type of valid way to manage blood sugars there. Sulfonylureas were the other one that I wanted to mention. Glipizide, glyburide, these are probably the most common agents that are used. Maybe glimepiride I see occasionally as well. It's recommended to avoid these altogether if possible in diabetes care. There may be exceptions regarding cost and things of that nature, but we've got so many medications now to manage type 2 diabetes. You got your SGLT2s now, your GLP-1s, and so on and so forth. So lots of medications that we can use. If you remember the mechanism of sulfonylureas, they directly stimulate the pancreas to release that insulin. And naturally, the more insulin you have, more insulin's released, it can increase the risk for hypoglycemia and that blood sugar dropping. Magestrol. So this is a medication that I have seen used periodically in geriatric patients, and it's used primarily to stimulate appetite and increase weight. It is not recommended for this purpose. The evidence of benefit in our geriatric patient population is limited at best and maybe even pretty close to non-existent. So that's a big issue. And then obviously there's risks with the medication. And the big risk associated with that is blood clots. So if you see somebody treated for a DVT or you see a new onset of a DVT or PE diagnoses, that's a situation where I go back, I look through the medication list, and I see, hey, are they on medications that could cause a blood clot? Classic example would be estrogen therapy. Another example would be Magestrol, like in this situation. So again, now medications, Magestrol isn't used terribly often. I think the word has gotten out that it's generally not appropriate to use for that purpose. But again, occasionally I do come across and see these things, and that's the reason why we try to avoid Magestrol use. All right, getting into some GI medications. So we've got PPIs. They can increase the risk for C. diff, pneumonia, fractures, certain GI malignancies, and it is recommended to avoid long-term use of these if possible. Now, there are some exceptions to this. So Barrett's esophagus is a good example, erosive esophagitis, peptic ulcer disease. If you've got a patient on a higher GI bleed risk medication, so let's say chronic NSAID use, and we can't use any other alternatives there, that's a situation where longer-term PPI use may be considered there. But again, if you've got a patient with just some dyspepsia, just some mild GERD symptoms, it's recommended to use those PPIs no longer than 8 weeks. So be sure we're reassessing these, and this is a great target for deprescribing, and I definitely have talked about this one in my book, Perils of Polypharmacy, in just case studies and situations where we can get rid of that PPI and not use it long term due to some of those risks that I mentioned. Another GI medication to think about is metoclopramide. Brand name is Reglan here. So this drug has dopamine blocking activity, and it can cause extrapyramidal symptoms as well as tardive dyskinesia if used long enough. So Again, another GI medication, definitely recommended to try to limit its use. Use it short term if it's absolutely needed. For gastroparesis is probably the main indication I see it utilized for. If we're using it for, nausea and other things like that, that definitely isn't a great indication to use it for. We've got a lot of other medications that are probably safer and not likely to cause some of those movement disorder issues. So definitely a medication to have your alert on if you see it on somebody's regimen, and do what we can to try to minimize use, minimize dose, minimize duration. A few others, these are probably less common, but I do see them occasionally used for GI spasms. So that's like hyoscyamine, scopolamine, dicyclamine. These medications are highly anticholinergic. And I mean, that's how they work in trying to reduce GI spasms. But again, just the anticholinergic nature of these medications in geriatric patients, some of the confusion, sedation, fall risk, those classic anticholinergic symptoms like dry eyes, dry mouth, and so on and so forth. These medications can definitely cause that, and that can be a big, big issue. So generally avoid the use of some of those GI antispasmodic agents. One last GI agent that I will mention, sometimes you get some patients that will pick up a bottle of mineral oil and use it orally for constipation management. This medication is not recommended for constipation. It can definitely cause some aspiration pneumonitis, some inflammation in there, and some issues with aspiration. So mineral oil should be avoided in geriatric patients as a form of management for constipation. Desmopressin, I can't say I see this medication used very often, but historically it has been used for nocturia, basically helping patients pee a little less at night or issues with that. It has a warning with regards to causing hyponatremia, low sodium. So, and it can be pretty severe. So definitely recommended to avoid desmopressin due to that hyponatremia risk. All right, NSAIDs. So NSAIDs do show up on the Beers criteria. I see patients use these quite a bit still. Geriatric patients. I do think some patients are fairly well educated on this, particularly if they take anticoagulants like apixaban or warfarin, for example. NSAIDs can significantly increase that risk for GI bleeds. So we really want to do our best, especially to avoid chronic use, and we especially want to avoid use in patients at higher risk for GI bleed. So I mentioned anticoagulants, of course, older age, greater than 75, corticosteroid use, obviously antiplatelets as well, so aspirin and Plavix and things of that nature. So these are all risk factors that are going to increase that risk for GI bleeding. This is a situation where if you absolutely need chronic NSAIDs, it might be a consideration to use GI protection or prophylaxis with a medication like a PPI, for example. So, again, try to minimize dose, minimize duration, minimize use whenever possible of NSAIDs. In addition to some of the GI bleed risk issues, they can exacerbate heart failure and cause some fluid retention. In addition to that, they can raise blood pressure. And in addition to that, they may exacerbate renal function issues. So they may contribute to some acute renal failure type situations. So definitely plenty of strikes against NSAIDs. So try to avoid them if we can at all possible. And if we do need to use them, try to limit their use to short-term and lower doses if possible. As we're wrapping up here, I've got a couple other analgesic spasm type medications here. So first and foremost, meperidine is an opioid type medication. Obviously, we've got risk of addiction and dependence associated with that. But the primary reason why it shows up on the Beers criteria is efficacy is not that great, And then we've got potential toxicity with metabolites in the medication itself. It can cause some neurotoxicity. It can increase the risk for delirium in our geriatric patient population. So definitely a drug, oromeperidine, to try to avoid there. And then last but not least, we've got skeletal muscle relaxants. Of the list of skeletal muscle relaxants, probably the most common that I see used are cyclobenzaprine and methylcarbamol. They are pretty anticholinergic, very highly anticholinergic. Again, sedation, confusion, fall risk. They're going to exacerbate dementia in patients with those symptoms associated with that. So it can be a challenge to use these medications in our geriatric patient population due to the significant anticholinergic activity. I will note that the Beers criteria does not include baclofen and tizanidine in relation to treating like muscle spasticity. They definitely have, some concerns of their own, but they are not included on the Beers list here. So with that said, I think that's going to wrap up the podcast for today. Please go to reallifepharmacology.com, sign up and subscribe there. Get your free 31-page PDF on the top 200 drugs. Great no-brainer. Simply an email is all it's going to cost you. And then we get you access. We let you know when we've got new content available as well. If you enjoyed this podcast today, please do us a huge favor. Leave us a rating review on whatever platform you're listening on, whether that be iTunes or YouTube or anything else. Also, if you have any comments, questions, ideas for the podcast, definitely don't hesitate to reach out to me at mededucation101@gmail.com. You can also track me down on LinkedIn, Eric Christensen, PharmD, BCPS, BCGP, and connect with me there. Thank you so much for listening today. I hope you picked up a few practice pearls, and I hope you have a great rest of your day.